Okay, so as I promised, we are starting over again with slide 16, and I promise not to accidentally bump anything and mess up the order of the slides. Anyways, so intellectual development disorder. So we are looking at deficits in intellectual functioning, social, and daily functioning, which basically we're thinking about our ADLs. So as far as intellectual functioning, deficits in reasoning, problem solving, planning, judgment, abstract thinking, and academic ability. So these students are seen in special education type classes in school. As far as social, they really have problems with communicating, language, interpreting, and social cues. They have a hard time reading people and kind of understanding how to respond appropriately and regulating their own emotions. And then the daily functioning, again, the ADLs. So we have to think about just the age appropriate activities of daily functioning at work or school, and even just performing basic, simple self care. So, application of the nursing process. So, assessment guidelines. We're always going to be assessing for delays. A really good way to assess for delays, of course, is to use the Denver Developmental Screening Tool, which you do in health promotion. So that is one way to look for delays. And so we're looking for delays in cognitive and physical development, lack of ability to perform tasks, or achieving milestones in relation to peers. So again, that Denver tool is really nice to be able to see where kids kind of ballpark figure where they should be at for their age. When we're looking at delays, we also really do want to kind of look at the child's strengths. So we don't overly want to focus on their deficits, but also focus on what types of things that they are able to do adequately. An example might be just looking at they're able to do any aspects of perform hygiene, dressing, or feeding themselves. So those are all important things to look at. We always want to be looking for signs of potential abuse or neglect because children with behavioral or developmental problems, they are at very high risk for abuse. So sometimes parents might feel angry at the child for having problems, and they may feel a great deal of distress with having to care for the child or to do extra things for the child that maybe they don't have to do if they wouldn't have to do if the child didn't have these deficits. And so that really puts that child at very high risk. So we always need to be alert to that. Nursing diagnoses, there's a really nice table on page 181. It's in purple, and it's basically signs and symptoms and nursing diagnosis for different types of um, problems that kids might have. So we can have all the way from impaired social interaction, impaired attachment, social isolation, activity intolerance, risk for self-directed violence, stress overload, lots of different diagnoses that we can think about when we're working with the child and also when we're working with the family. So we're always wanting to make sure that we're identifying appropriate outcomes. Some examples listed in your book are like using spoken language to make or respond to requests, engaging in simple social interactions, assessing and accepts assistance or feedback regarding behavior without frustration, tolerates social interaction for short periods of time without becoming disrupted or frustrated, and refraining from acting impulsively towards self or others when frustrated. Your book also mentions that a good outcome for the family, that if they're in denial, that the family would come to acknowledge the existence of the impairments and then, and be able to work on that effectively. So, implementation, psychosocial interventions. So children with these types of interventions need a lot of psychosocial interventions, and many times nurses are providing these interventions through different types of early intervention type programs. School nurses actually tend to become very involved with children like this, and can actually end up coordinating other different types of resources and also working with the family. And actually, it is a requirement that public schools provide services and assist children with these emotional or developmental delays to participate in school. So, if any of you are interested in school nursing, that might become a very important aspect of your job. And as part of the nursing process, we're always evaluating care, and the book really speaks to that nurses really use a strength-based perspective. Again, we really want to make sure that we maximize their potential and really look at the things that they are able to do and try to maximize those rather than just looking at the perspective of their what their deficits are. I guess as part of the evaluation process, we also just really have to look at the long-term effects, and maybe some of our short-term goals are met and we are evaluating that those are met, but we really have to think about and help the family plan towards the future, because the goal then would be to move this child into successfully into adulthood, in addition to having their developmental delay. So autism spectrum disorders. So these patients have deficits in social relatedness and relationships. So, being that this is a spectrum disorder, again, we have to think about that continuum, and there are many different degrees of impairment when we are looking at kids with autism spectrum disorders. And so, part of that social relatedness difficulty could be that the child is just completely unaware of other people, unable to form relationships, unable to give eye contact, no kind of back and forth exchange whatsoever, and others are much, lower on the continuum. I guess as far as symptoms go, you would say they're lower on the continuum, and they're much more able to communicate and to tolerate some types of social interactions. One of the videos that I have given you is to watch is on Kim Peek, who is the real Rain Man. So that's who they based the movie on. And there's a couple of videos out there on YouTube about him. And I don't remember I think it was in a different video than the one I posted. But in one of the videos, his dad kind of speaks to the fact that he, has all these wonderful um, advantages as far as his brain, as far as reading and memorizing things. In the video that I posted, you're going to be amazed at some of the things that he is able to recall. His brain is absolutely amazing, but he can't do his own ADLs. He needs somebody to. Well, actually, he passed away some years ago, but prior to that he really actually needed somebody to help him with his ADLs. He was not able to get up in the morning, perform self-care, dress, eat appropriately, just normal basic ADLs he was not able to do. And even though he kind of seems in the video kind of like he's a bit like engaging, he really does lack empathy in his interactions with other people. So that's typically the type of things that you're going to see. I also have, I know I put another video out there too on autism spectrum. So it's definitely always a good idea to watch the videos I post to kind of make some of these concepts kind of come alive for you. Speech patterns can be stereotypical or repetitive, so not really expressing thoughts and ideas in a coherent way, just mostly using words in more of just a repetitive way rather than actually trying to communicate meaning. They have obsessive focus on specific objects, and sometimes those objects are things like mechanical things, like even looking at like an old clock and watching the parts in the back move versus playing with a toy or something, or just really being fixated on specific things. I've had some students in the past give me some examples just from their own observations of families and friends, children with autism spectrum, and that sometimes it seems like mechanical objects and things with gears are things that they really can sit for hours and watch. So that's something that we really have to be looking at. Over adherence to routines or rituals. So another story from a former student is that they knew a friend who had a child with autistic somewhere in that spectrum. And the child, it was really a difficult thing for that child to tolerate a shopping trip to the grocery store. So the mom would always kind of try to do the grocery shopping in the same order, going up the same aisles in the same order every time. And then at the end of the shopping trip, if the child was able to maintain their behavior, then they would go to the bakery section, and the child liked a specific type of cookie. I think it was an M&M cookie. Anyways, so this one time, this person took their child on the grocery shopping trip, and they were going up and down the aisles, and everything was going okay. And then they got to the bakery, because now everything was good. The child maintained control, and they did not have that particular type of cookie that day. So the child, guess what? Absolutely lost it. So that over-adherence to rituals and routines really can't be underestimated, how important it is that they stick to some kind of ritual, and the difficulty they can have when something doesn't go exactly as planned. So that's a really great example. So, another child might have been upset or disappointed and said, well, okay, I'll pick out a different one that I would like just as well. But nope, somebody with autism, that's it. They've lost it because they wanted that specific type of cookie, and it's not there. It's not available. So yeah, that really, we can't overestimate the importance of that, or underestimate the importance of that it's something that is very likely to set them into behavioral discontrol. They have hyper or hyporeactivity to sensory input. It was actually interesting because I've noticed in a particular setting a little girl that I know with autism, and she seems to be fairly severe because she is really nonverbal. She makes sounds, but she doesn't communicate verbally at all. And eye contact is really, really lacking. But whenever a particular person around her talks too loudly, or even like starts singing loudly, she absolutely cannot tolerate that, and she immediately puts her hands up and covers her ears. And sometimes that'll do the trick, but there have been other times where I've observed her to absolutely have a meltdown after that occurred, because she just couldn't tolerate the sound of that person's voice. It was so very, very loud for her. So most of the time, it says you can have hyper or hyporeactivity. So sometimes you could be yelling at a child and saying, hey, come here. Maybe they're going to cross the street and they're in danger, and you're yelling at them and they seem like completely oblivious. So that can happen also. But I guess I've witnessed more often that hypersensitivity, and that they just can't tolerate loud songs, loud music, loud people. And if sometimes people are well-meaning, and I've seen someone reach out and try to touch this little girl and try to like comfort her when she's having a hard time, and that doesn't usually go very well either. She seems to be okay with her mom and dad, but that's about it. But even then, you definitely have some deficits in relationship. She doesn't have that normal bonding that you would with a parent figure. Extreme resistance to change really goes right along with the over adherence to routines or rituals. So anytime that ritual is interrupted, then those kids really have a hard time. I've also heard some stories about kids with autism, and how family, especially extended family and relatives, often don't really understand this disorder at all. And I can remember a particular situation where there was going to be a party, and the parent of the child was kind of saying, no, I don't think we're going to go to this big party at your house. And it was something, for a significant event, a graduation or whatever. And of course, the family was very upset because, you should just bring that child and they should just learn how to behave appropriately. Well, it's not so easy when you have autism. It really is a neurodevelopmental disorder, and that child can't just change their behavior automatically. And there are triggers. There are certain things that absolutely do make it worse for that child. So, sometimes you can be on the outs with your family because you understand your child and they really don't. And they think, again, it's a discipline problem. It's something that the child should just be able to learn and overcome. And truly, it's not that simple. So going something to a party can just be so completely out of that child's realm that that could be enough to set off a behavioral disturbance. So, and again, these autism spectrum disorders appear in early childhood, and really from infancy to toddlerhood, that's kind of the age where you start to pick up on some of these changes. So some of those first things that you're looking for, perhaps, or that you notice, are when the infant fails to be interested in others or to be socially responsive through eye contact and facial expressions. Some children can show a little bit of improvement, like during their development, but puberty can kind of be that turning point towards either improvement or possibly deterioration. So the next couple of slides show a few different cartoons um, related to this topic. Okay, I lied. One more slide before cartoons. So just really a very quick recap of what we talked about. We talked about assessment. Some guidelines are on page 182. We talked about some nursing diagnoses that we would have for the patient. Possibly the family might be in denial. We can include the family there. We always are trying to have goals, really maximizing their potential. And for the implementation, psychosocial interventions, we always should be making sure, and as nurses, really advocate for that child to receive and to be part of an early intervention program. It can absolutely be huge in terms of that child doing better and improving to the point where they may even have some level of independence. Psychobiological interventions, we haven't really talked about those yet, but there are a few medications like Risperdal and possibly Abilify that might help some of the help them to relate a little bit better to other people, decreasing some of their anxiety and possibly compulsive behaviors and agitation. So Risperdal and Abilify, they can treat children 5 to 6 years of age and older. The SSRIs, which are antidepressants, are also popular medications used with this population. They can help with their mood and their anxiety level. So that might help them to actually tolerate new situations a little bit better. And of course, evaluation, talked about that already. Always looking at is the patient meeting their goals and where are they at? And then you always reevaluate and see if you need to change any of your interventions. So now some cartoons. So you see the autistic spectrum looks something more like this. So it's kind of like they show like a little color wheel: executive function, perception, motor skills, language, and sensory. So it's really a combination of so many different deficits. And actually, they can have some not just deficits, they may also have some strengths in some of these areas. So we always have to remember that. So again, think of Rain Man as a really good example. So again, see how some of the writing is a little bit upside down and kind of hard to read. But again, basically what I like about this is that it's basically saying no to like labeling people. And so we really have to think about that. I actually know a friend who has a child who is autistic and another child who was born without any type of developmental issues at all. So this friend calls his daughter his autistic, and he calls his son his neuronormal child. It's like, wow. So talk about labeling your kids. That is really something else that we should kind of help to work against. We shouldn't be labeling. We should say a child with autism or on the autism spectrum. So understanding, acceptance, accommodation, neurodiversity are all things that we should be kind of thinking about rather than putting labels and judgments on these kids. And I really like this cartoon because, again, it kind of shows a continuum from not autistic all the way to very autistic, and sometimes the struggle that kids go through. And the problem with thinking of the spectrum in this way is that a perception of an autistic person also becomes linear, and it really isn't a linear problem. So somebody's saying, probably the parent, "You're only a little autistic, Archie." And he says, I still don't understand. Can you be less vague?" And she's saying, "You're able to have a normal conversation with me and act pretty normal. You're not severely autistic." So, and then down at the bottom, I'm guessing that's his mom talking to him. I could be wrong. But anyway, so now on the bottom, it says, "And so you see, if someone thinks you're on a low end of the spectrum, this often happens." So she's saying and pushing him and saying, "Archie, you can handle all of this just fine. You're not that autistic." And then if you look over on the bottom right, it's basically saying new situations, smart, tight clothing, don't stim, which is stimulation, too much noise, lack of routine, loud conversations all at once, don't fidget, be more organized. So that's kind of how overwhelmed that kids can feel when they're probably on that lower end of the spectrum. So I just kind of liked those cartoons. And actually, this is kind of nice too. The little boy is saying, "Mom calls it autism," and the tree is speaking to the child and saying, "Call it what you want, but not everyone can see like you." So basically, giving this child some encouragement that, like, their differences maybe are making them perhaps more special than anybody else because they have a unique perspective and they see things that we don't see. They experience things the way that we don't experience. So it's kind of a nice way to provide some support for somebody that has autism. Okay, now we're going to be talking about attention deficit hyperactivity disorder. So the basic characteristics are an inappropriate degree. And so inappropriate would be kind of the key word. Inattention, impulsiveness, and hyperactivity. Because if you think about a child in general, lots of children have trouble paying attention, being impulsive, and being sometimes hyperactive. So, we have to really learn to understand the difference between normal childhood behavior and what's kind of developmentally appropriate and when it becomes an illness. And this is one of those diagnoses that, again, many health professionals don't necessarily feel that it's a real diagnosis, feel that it's more of a discipline problem. And certainly circumstances and the quality of your environment and your parental ability to provide you with a routine and structure and support and all that certainly can impact a child with ADHD. But there actually are people that don't think that it's a real diagnosis. So again, in the medical profession, sometimes we have conflicts in what we believe or don't believe. So really the main reason I even had you do a discussion question on this is because I think what we really need to do as nurses is always look for the research. We always should be looking for the scientific evidence. So, and I think more research certainly is needed in this area because, again, there's lots of different thoughts and opinions out there, but really as nurses, we should be looking to research and evidence-based practice for guidelines as to how we work with patients with this type of disorder. Just kind of going along with the whole idea of this not being a real diagnosis, I read an article a few years ago, and it was called "Why French Children Don't Have ADHD." And this article spoke to the very low percentage of children in France that develop ADHD, and really feeling that it's because that they are much more structured with their children and set limits from the time that a child is born. They have limits that they set on them that we don't do in the United States. For an example would be feeding. So if this article basically said that if a French baby is hungry, the parent, the mom, will wait until the next feeding the next scheduled feeding. So they feed their children on a schedule rather than by demand, which is probably what we mostly do in the United States. I don't teach, OBGYN nursing, but I think the last time I knew that that whole aspect of feed the child when the child is hungry seems to be the most popular concept. So, but they don't do that in France. Apparently, if the baby cries, they comfort the baby, of course, but they're not going to jump in and feed the baby until the next scheduled feeding. And as children are getting a little bit older, so now they're into toddler and preschool age and school age, they basically are doing the same thing. They are having everything, their meals are scheduled, and they don't just feed the child whenever the child is hungry. They don't carry a bag of snacks everywhere, have snacks in the car and snacks everywhere and all over the house. And anytime the child whines a little bit, here, give them a snack, which we kind of let kids eat whenever they want sometimes. I mean, maybe there might be some people that have, individual variances always occur. There might be some people that have more structured routines about how they feed their kids. But, most of us in the United States, we definitely give kids snacks on a pretty regular basis. So, they have snacks usually built into the school day. When kids come home from school, they get a snack. They might get a snack again before bedtime. And they don't do that in France. They're kind of more rigid about that, I guess, more structured, so that the child actually, they feel, learns to delay gratification. So rather than just giving them something every time they peep, giving them some type of food, they kind of let them deal with their feelings. And they feel that that has contributed to um, having a lower percentage of kids with this disorder. So whether that's real or not, I don't know. I guess, again, you have to look at research and what kind of hard research was done to come to this type of conclusion. So as nurses, we always have to be a little bit skeptical. It was a really interesting article and had some good points as far as cultural differences, but truly, again, I kind of want to see the science, and I want to see some actual good research that's being done in this area. And it is possible that just having structure and limits certainly can help a child with this disorder. So anyways, inattention, impulsiveness, and hyperactivity. For inattention, some of the things that we're looking at is failing to pay close attention to details, making careless mistakes in schoolwork or at home. They miss details, so their work is sometimes inaccurate. They have difficulty sustaining attention in their tasks or even play activities. They don't seem to listen when you speak directly to them. Their mind seems to be elsewhere. They don't follow through on instructions, fail to finish schoolwork, chores, or other duties in the workplace. They have difficulty organizing tasks and activities. They have a hard time keeping materials and belongings in order, messy, disorganized, poor time management, fails to meet deadlines. They avoid, dislike, or are reluctant to engage in tasks that require sustained mental effort. So schoolwork or homework, things like that. They lose things necessary for tasks, school materials, books, tools. Easily distracted by extraneous stimuli, especially, and forgetful in daily activities, doing chores, running errands, so returning calls, paying bills for adults. So adults can actually have this disorder too, keeping appointments, all those types of things. So that's the inattention. The impulsiveness has to do with so some examples of that could be blurting out an answer before the question even has been completed, finishing other people's sentences, maybe not waiting for their turn in conversation. They interrupt people a lot. They have difficulty waiting for their turn, waiting in line, interrupts others, butts into conversations. They may even get to the point of intruding or taking over what other people are doing. So as you can see, those things would be kind of difficult to manage. And then the hyperactivity is fidgeting, leaving their seat in a situation where you're supposed to be in your seat, so either at work or in the classroom, running around, climbing, things like that, unable to play or engage in any type of activity quietly. They're on the go. They're acting as if they're driven by a motor. They talk excessively. So all of those types of symptoms we would be assessing as a nurse. So we would be looking for those inattention, impulsive, and hyperactivity symptoms. So assessment, we're looking at their level of physical activity, their attention span, their talkativeness, if they're butting into people, if they're not able to wait their turn, all those things that we just mentioned. And again, very nice table on the top of page 184 in orange, and basically it's the DSM-5 criteria for ADHD. So as I went through some of those symptoms, maybe you're thinking, social skills would probably be difficult to interact with and get along with somebody that's displaying those symptoms, especially if it's really to a very high degree. So sometimes these kids do have a lot of trouble with peer relationships. They're strained because they can't take turns. They just don't have good boundaries, sometimes intrusive behaviors, always interrupting. Again, depends on the degree of those symptoms, but that they really can have a lot of trouble with social skills. So that brings us to some comorbidities that kids do experience with ADHD. So one of the biggest comorbidities is actually substance abuse. So we really have to think about this very carefully when we're assessing teenagers. Many times these kids also, besides drugs and alcohol, they also might be overusing caffeine. So all of those drugs, alcohol, caffeine are ways to try to self-medicate. So the caffeine is a stimulant, and of course we treat patients with stimulants, or most of the time, with this disorder. So it seems to have that paradoxical effect in the brain. So it's very possible that they're really trying to deal with their symptoms by using some of these substances. So that is something we always need to very, very carefully assess for. Some other comorbidities that your book talks about are that sometimes some of these kids are also diagnosed with oppositional defiant disorder or conduct disorder, which we're going to be talking about next. And they can also have difficulties with their mood and possibly some specific learning disorders. But many times these kids do have depression and anxiety, usually goes along with depression, so they can have those types of symptoms. They definitely have issues with self-esteem, many times because they may be very bright, but they're just not able to keep up with their peers because their symptoms are really getting in the way of them having good academic success. So, and anytime you have low self-esteem, we always have to think about depression and then suicidal ideation. So always things to think about when we're looking at comorbidities. As far as nursing diagnoses that might apply, possibly ineffective coping, ineffective role performance, risk for ineffective relationships, possibly self-directed violence, ineffective role performance. Yeah, there's lots of different ones that really could apply. Again, I'm kind of referring back to that table. It's on page 181, and it's basically a table for signs and symptoms, nursing diagnosis of the neurodevelopmental disorders. So there's a lot of different disorders kind of mixed in there, so we can kind of pick and choose and think about which ones are going to be applying to people with attention deficit disorder. And then, of course, our outcomes, we always want the goals to be relating to targeting that hyperactivity, impulse, self-control, freedom from injury, improved relationship, good self-esteem and self-identity, coping skills, and overall good family functioning. So that's what we want our outcomes to be. So again, a couple of comics. Thoughts fly lightning fast. Can you control them? So the kid is kind of sitting there in school. Looks like his teacher's pretty unhappy. And it looks like he's got lots of other different things that he's thinking about. And his book is kind of on the ground. And it looks like he's not really doing what he's supposed to do in school. So it can be very frustrating for teachers and then also for the child, because the child is more than likely not going to be doing their homework. They may not be passing. And again, that really does hit their self-esteem pretty hard. So again, another comic strip just kind of showing what things we struggle with: time management, sitting still, short-term memory, prioritizing. Just again, just a little capsulization of what kind of is going on. And this one is really kind of interesting. So there's huge, enormous, looks like a monster or dinosaur stuff you're supposed to do today, looming over this tiny little person. And it says, oh, look, more amusing animal pictures, and just really not paying attention to what the big picture is, what things he's supposed to be doing, but just kind of getting distracted by other things. And it also says on the bottom, 3 p.m. still in underpants. So they have not even done their ADLs yet, and they're just very, very distracted by things going on around them. So, little case study. Victor, 5, will soon be starting kindergarten, and his dad, a single father, is very anxious. I have no idea how Victor is going to make it in school. He's completely out of control. I have trouble getting him to calm down. When he was little, I was kind of proud of how active he was, running from one thing to the next. I took it as a sign of curiosity and intelligence, but as he's gotten older, he's still like that, only he can't calm down and sit still for anything like the other kids his age. Something's got to change. So now Victor has started kindergarten and still exhibits the same problems his father expressed frustrations with earlier: his hyperactivity in particular, and his inability to listen when his dad tries to correct or slow him down. So Victor is assessed today for the following: level of physical activity, attention span, talkativeness, social skills, and for other comorbidities. So again, just kind of what we have just talked about the last few slides. So we have to think about the implementation, the psychosocial interventions. So behavioral techniques definitely can be very, very helpful. Psychobiological, pharmacology. So we're going to be looking at a slide that's going to talk about some different types of medications that we can use. We're helping these kids with their psychosocial interventions. We're trying to help them to work on better, effective coping mechanisms. We were trying to help them to avoid blaming other people, denying their responsibility for their actions, things like that. So we want them to overall to be showing more adaptive coping mechanisms, and to have just better overall social skills with other people. If these kids are hospitalized, usually it's for another reason, not specifically for ADHD, but they may have that and other comorbidities. So we definitely want to look for danger to self or others, and we have to make sure that we are keeping that child and other people around them safe. Family teaching and therapy is actually another very important task for the nurse. Of course, therapy would be more the advanced practice nurse, but family teaching would definitely fall within the realm of the staff nurse. So medications for aggressive behaviors, usually if a child is in the hospital and they really are out of control, sometimes that they are using antipsychotic medications, because they can really reduce the impact of violent behavior, hyperactivity. But sometimes, because of that high risk of tardive dyskinesia, we really only want to use those very, very short term, just for acute episodes. Some of these kids might be on some mood stabilizers, and possibly some, we're going to talk about some stimulants pretty soon. They may also be on some anti-anxiety or even lithium as far as a mood stabilizer. So it's very possible to use those. In evaluation, we're always looking at the effect of our interventions and medications, always assessing for the hopefully a positive response and hopefully the absence of any side effects. So getting back to Victor again, he's diagnosed with ADHD after being assessed both at home and at school. To begin with, a psychiatric mental health nurse works with Victor to help him change his pattern of misconduct, working with Victor's father as well to help him develop internal controls and help them both improve coping and support. Victor expresses delight over a few of the cognitive behavioral therapy games aimed at developing problem-solving skills and conflict resolution. Use of medications are discussed as a possibility. So let's look at some of the medications that are typically used for ADHD. So stimulants, basically two classes of medication, stimulants and non-stimulants. So stimulants, some examples are Ritalin, Adderall, Concerta, or Vyvanse. Those are the ones that I see most often prescribed in the hospital. They're used to improve attention and task-directed behavior, reduces impulsivity, restlessness, and distractibility. So it improves some symptoms and reduces other symptoms, all for a positive benefit. Side effects, though, the biggest side effects usually are decreased appetite and insomnia. Of course, there are other side effects that we have to watch out for. And many times, I know that when we're giving these medications in the hospital, usually for Ritalin and Concerta, which is a long-acting form of Ritalin, one of the first side effects that's like really big and in bold is usually sudden death as a side effect. And I've actually had a few students say, "Should I even be giving this?" With that as like a side effect, and it is a side effect, and of course it should be in bold because it would be a very serious side effect, but usually it is considered very safe medication. So Ritalin and the long-acting form, it's considered very safe. However, it may cause sudden death. Usually the usual cases would be kids that have some kind of and teenagers usually that have some kind of an undiagnosed cardiac condition, and it's just somehow gotten missed, fallen under the radar, just never been assessed, and sometimes during a sporting event or during extreme levels of pushing themselves physically in which they would have possible cardiac and respiratory issues. That's usually when we would see that sudden death, but overall these medications are really considered to be pretty safe. For managing these two very common side effects, decreased appetite and insomnia, there certainly are things that we can do as nurses or recommend to families. The decreased appetite, sometimes the child, if they're on a long-acting version of Ritalin, then there are times where the medication kind of is more effective, and some periods that it's less effective. So it's better to try for that child to get a lot of their calories in at the times when their appetite is best. So if they take it, they can have a good breakfast and maybe a milkshake or something, or a health shake or something first thing in the morning, like before they take their medication or with their medication. That might be a time of day when their appetite is really great. Perhaps lunch isn't going to be so good, but maybe dinner or a bedtime snack might be, their appetite again might be a little bit better. So it's kind of a matter of trial and error and trying to see when they're at what times during the day, depending on if they're taking short acting or long acting, that their appetite is kind of at its peak, and try to really maximize that. Insomnia, again, if it's a long acting, usually you take it the medication first thing in the morning. So hopefully by the time the child goes to bed at night, that most of it is at least kind of worn off so that the child is able to get some sleep. I've also heard and read articles saying that it's kind of helpful too to make sure that child gets enough physical activity during the day so that they actually are tired at night, and that will also help their sleep. And if they're also on the short-acting version of Ritalin, then they should probably take if they're taking a couple of different doses during the day, the last dose should be given no later than 4 o'clock in the afternoon. And perhaps if the child's younger and gets to bed early, then maybe even earlier than that, sooner than that would be their last dose. So the risks that you have to think about for Ritalin, Adderall, Concerta, Vyvanse, these medications are controlled substances. They can and are abused. They are sold on the street. There is street value for these medications, and a high probability of kids sharing their medications or selling them to other kids. So definitely something to keep our eyes on, and do some family teaching about that. Read an article a while ago about how it's very popular for college students to be taking other kids' Ritalin, and again, sometimes there's street value out there. So if you buy somebody else's Ritalin so that you can stay up and study longer, it's certainly not an appropriate use of the medication, but it does happen. So that is definitely a risk that we always need to pay attention to. So then there's some non-stimulants. So these are not controlled substances. Strattera is kind of in a class by itself, and it's actually chemically related to the antidepressants. And so therefore it may take up to 6 weeks before it becomes effective. Whereas Ritalin and Adderall, Concerta, Vyvanse, those are going to be acting actually pretty quickly. So this takes a bit longer, and the Capve and Intuniv, those are both centrally acting alpha-2 adrenergic agonists. So clonidine is actually Capve. So we just talked about clonidine. Again, it's a very interesting medication used for a variety of different reasons. And Intuniv, which is guanfacine, which I have definitely seen used in the hospital. They're FDA approved for the treatment of ADHD, so they could be used alone or in conjunction with other medications. We just have to look at clonidine as far as having side effects of somnolence, fatigue, insomnia, nightmares, irritability, constipation, respiratory symptoms, dry mouth, and ear pain. Now, it's interesting that nightmares is a side effect of clonidine, because I know that they are starting to give that at bedtime for patients with PTSD for nightmares, because sometimes those nightmares can be enough to really prohibit that person with post-traumatic stress disorder from getting a good night's sleep. So it's kind of interesting that that is a side effect. But anyways, so, and also think about, obviously, if it was first formulated to lower blood pressure, then lowered blood pressure could also be a possible side effect that we would have to watch out for. I know that when we're giving this for opiate detox, then we are really monitoring that person's blood pressure very carefully, and usually have some strict guidelines as to what the cutoff is as far as when we can and cannot give that clonidine. Some side effects of the Intuniv are somnolence, again, lethargy, fatigue, insomnia, nausea, dizziness, hypotension, and abdominal pain. So most of those side effects really should be able to be monitored and taken care of very carefully. So, and these types of medications are better for people with anxiety, tics, and substance abuse. So they can't be, well, I guess you could abuse anything. So I shouldn't say they can't be abused, because people certainly can take more of something than is prescribed, but they don't have street value, and they are not controlled substances that way. So if they are prone to substance abuse, they're not going to get perhaps a high or a buzz that they might from medications that are, that are controlled substances. So the other thing to kind of think about too, which comes up, your book doesn't really talk about it, but you may have heard the term drug holiday before. And so sometimes this is recommended by the prescribing either physician or advanced practice nurse, that when the child is not in school, that they take a drug holiday, and perhaps over the summer they're not on their medication. So that's helpful only if the child isn't going to be participating in any kind of structured activities. So it really does help in terms of just letting them kind of be for a while, and they won't experience some of those side effects. And in general, it's just always better to not have kids on medications, if at all possible, on a continuous basis. And then usually what happens is, towards the end of the summer and school is starting in a week or two, kind of start the child back on the medication, so they kind of get used to it again, get back into the swing of things. And the only exception that I've ever read to the drug holiday during a summer would be that if the child is scheduled for a camp experience. So if they're going for like a week camp away from home somewhere, they may actually have better behavior and better luck with, following directions, if they take their medication during that time that they're going to be attending a camp type situation. So, case study, audience response question: which statement demonstrates that Victor's dad understands the diagnosis of ADHD? A, Victor will never be able to graduate or go to college, but may be able to learn a vocational skill. B, Victor's performance will improve in a structured setting that provides rewards for appropriate behavior. C, nothing is wrong with Victor. The school hasn't provided qualified teachers in classroom settings. Or D, Victor is just going through a stage. The problem will go away with time. So I'm hoping that you're picking B, because some of the other statements really could just indicate that the parent is in denial, or perhaps just that they just don't understand the diagnosis at all and think that it isn't anything that can be dealt with or improved. So the Center for Quality Assessment and Improvement in Mental Health Measures, basically quality improvement is part of QSIN, and so improving the quality and effectiveness of nursing care for kids is definitely a continuous ongoing process. So we're looking at things like access to child specialty care for treatment of things like depression, family involvement in ADHD, stimulant medication treatment for ADHD, antipsychotic treatment for childhood psychosis, completion of treatment for substance use disorders, and referral to post-detox treatment services. So all of these areas in general would help to improve child and adolescent mental health care. So, audience response question: which child would be most difficult to diagnose for any neurodevelopmental disorder? So 3, 5, 8, or 12. So I'm hoping you picked 3 because I believe I said earlier that the younger the child, the more difficult it is to diagnose just because of their lack of intellectual development, cognitive, emotional. So very difficult to diagnose a younger child. Another audience response question: a 4-year-old frequently lashes out in anger at adults and other children. This child's style of behavior is an aspect of neurobiology, temperament, resilience, or culture. So I'm hoping that you think it's temperament. So a 4-year-old, again, isn't very far along developmentally, so it's just very possible that it's an inborn temperament issue, that perhaps that child has always been more fussy and emotionally reactive. Okay, I think I'm going to start a new recording for chapter 21. So we're continuing with learning plan 6, impulse control disorders.